Last section we're going to talk about in this class is mental and cognitive disorders. So, in the book, chapter 14 has a little bit about it, not a ton. The recommended pages for you to read are listed in Canvas. I'm going to expand on the information a little bit because I feel like it needs to be expanded upon. The Several years ago, I took a really interesting workshop with a clinical psychologist, and it was mental health disorders for the health professional. And so everybody in the audience, everybody in the class were nurses, hospital administrators, physical therapists, etc., healthcare professionals. And even though a lot of us don't specifically work with people with mental health disorders, people don't leave their mental health disorders at home when they come into physical therapy. So it's always nice to know about these things, I mean, as part of the curriculum. And um, just awareness is important. So I always feel like everybody that walks into the clinic, no matter what they bring with them, I have to meet them where they are. So if I know more about what's going on with them, that can help me work with them. So the learning objectives for this and the next lecture, in this lecture, we're going to talk more about the anxiety and somatoform disorders. And in the next one, we're going to talk more of the cognitive and schizoid disorders. So this early signs of Alzheimer's, three characteristics of um, decrease in cognitive function and how they could interfere with daily life. If you hear something that sounds like a dog drinking water in the background, it's a dog drinking water in the background. So I want you to be able to compare three signs of schizophrenia with three signs of depression. How antidepressant drugs act to reduce anxiety disorders, signs of anxiety disorders. They also help with depression. Describe a panic attack and define obsessive compulsive disorder. So the first part, we're going to talk about anxiety and somatoform disorders. And the second part, we're going to talk about depressive and cognitive disorders. So mental disorders are classified in the Diagnostic Statistical Manual of Mental Disorders. The fifth edition, I believe, is the current one. Things change between edition to edition. So sometimes they add new things, and sometimes they take things out or put things in. So things that had previously been considered mental disorders now are not, and things that either hadn't been invented yet or whatever get added to new editions. So mental disorders are considered dysfunctions in the area of behavior or personality. So biochemical or structural abnormalities may be identified with particular dysfunctions and often are, which I think is interesting. A lot of the things that we think of mental disorders are biochemical disorders. And you know me, it's all about neurochemistry, right? And so there could be a genetic component possible with some of the different disorders. There are psychotic illnesses that include schizophrenia, delusional disorders, mood disorders, anxiety, and panic disorders. And one of the new things that came out in the fifth edition of the DSM, which came out several years ago, they don't put out a new edition every year. It's usually a while before they put out a new edition. But some of the new things that came out were anxiety disorders after drug use, after certain drug use. So that was a new thing that came out in the fifth edition. So some other aggravating factors can cause these psychotic illnesses. So the types of disorders that we're going to talk about in this class are anxiety disorders, somatoform disorders, or factitious disorders, and they are very interesting from a physical therapy point of view. Mood disorders, schizophrenia, cognitive disorders, and eating disorders. So anxiety disorders, that's the first part. All of the art that I used in these slideshows, I got from a website that features artists who have individual disorders who drew or painted these images, and I think they're amazing. So just know that. So the definition or presentation of anxiety disorders, it's feelings of fear and apprehension that are out of proportion to the situation. So the cognitive presentation is worry, going into panic, maybe. And it's sort of the worst case scenario thinking. So misfortune turns into impending doom. So it just amplifies things. The behavioral presentation can often be avoidance of certain situations, situations that cause the anxiety. So some people have anxiety with leaving the house, they just don't leave the house. So that's their behavioral presentation. Biogenic causes of anxiety disorders can include, but are not limited to, dysfunction in the locus ceruleus, which is an area of the brain where norepinephrine is created. The neurons in that area create norepinephrine. It's located underneath the cerebellum, very close to the brainstem, and it's the center of our anxiety system. So, doesn't that make sense? There's dysfunction in that center, and that causes us to manifest anxiety disorders. Um, the anxiety reaction can be stimulated by thoughts or anxiogenic substances. So substances that cause anxiety, like caffeine can trigger, if you already have an existing anxiety disorder, can trigger in some people, or stimulants like cocaine can stimulate anxiety disorders. The reason antidepressants are used in anxiety disorders is because they have been found to raise the threshold of the anxiety system. So you still might have that underlying worry, but it doesn't go over into panic. It raises your threshold. You can tolerate more before it gets unbearable, basically. So, under the umbrella of anxiety disorders, there are all these different disorders, which probably most of us have heard about. So, panic disorders, and I'll talk about each, I have a kind of a slide on each one of these. Generalized anxiety disorder, or GAD. Obsessive compulsive disorder is an anxiety disorder, and that's OCD. Post-traumatic stress disorder, PTSD. And the pharmacology that is usually used for any of these types of anxiety disorders are antidepressants, which we just said raises the threshold, and anti-anxiety drugs. So those are the things that are used to pharmacologically treat these type of anxiety disorders. They also cognitive behavioral therapy and traditional talk therapy. Lots of psychotherapy can also be helpful in treating anxiety disorders. So panic disorders, it's a severe, frightening episode. A panic attack is a severe, frightening episode of apprehension and feeling of impending doom. So the physiological responses are sweating, a feeling of choking, heart palpitations. A lot of people who have had panic disorders say they can tell when one is coming on. They start to get those physiological responses. There may be a genetic factor implicated. There's an increased discharge of neurons in the temporal lobes during a panic attack. And there are some neurotransmitter abnormalities, including norepinephrine, serotonin, and GABA. So the interesting thing about panic disorders is the current thinking is that a panic attack, an actual panic attack, only lasts about 3 minutes. It only seems like it lasts longer to the poor person experiencing it. So I have had people have a panic attack in the middle of a therapy session. Not the ideal setting. There's no ideal setting for a panic attack, really. And it's being able to get the person comfortable and a place where they can be calm down a little bit is helpful. So generalized anxiety disorder is basically persistent high levels of anxiety and excessive worry over many life circumstances. One of my friends called it free-floating sense of anxiety, which just attaches itself to whatever's available, which I think that's a pretty good um, explanation. Um, The physiological response, heart palpitations, similar to a panic attack, but maybe not that extreme. Muscle tension, restlessness, poor sleep, and poor concentration. And unfortunately, a lot of anxiety disorders are characterized by poor sleep, which leads to poor concentration. And so poor sleep doesn't do anything, it makes everything worse. But that impaired concentration and irritability and restlessness. And then, of course, if you're not sleeping and you have increased muscle aches and soreness, then you're probably going to be fatigued as well. So all those symptoms kind of feed into each other, which is never a good thing. Obsessive compulsive disorder involves a couple different things. So obsessions are intrusive, repetitive thoughts or images that produce anxiety. Like say that you're afraid to leave the house and your obsessive image is you imagine your house burning down, and it produces anxiety. So it's that intrusive repetitive thought, and it could be anything that produces anxiety. Compulsions are the need to perform acts or thoughts to reduce anxiety. So some people, if they're afraid to leave the house, they'll lock and unlock the door a bunch of times, or they will check that the stove is off a bunch of times, that sort of thing. And so obsessions and compulsions may occur together or they may occur separately. But most people have obsessive compulsive disorder um, don't have conscious control over their obsessive thoughts or their compulsive actions. But they get increased anxiety when they attempt to prevent or stifle those thoughts or actions. The physiological responses are similar to generalized anxiety disorder. And the thing is, though, is I think a lot of us have, um, you have anxiety at times, you have obsessive compulsive behaviors or something at times. But when it crosses over the line of a disorder is when it's disrupting your life to a significant degree, if that makes sense. So everybody has times when they're sad, but that doesn't necessarily mean you have clinical depression. And everybody has times when they're anxious, but that doesn't necessarily mean you have generalized anxiety disorder. So to me, when it crosses over into a disorder is when it's disrupting your life. So, post-traumatic stress disorder is an anxiety disorder that is developed in response to extreme psychological or physical trauma. The trauma may be to the person's self or a close other or generalized trauma. So, PTSD has commonly occurred to people who go to war, people who experience really horrible things that don't happen in really day-to-day life, and that's that generalized trauma. Um, the physiological responses are similar to generalized anxiety disorder, and it has a side order of depression just to go with it. So they the canine companions service dogs, they have a track that's specifically for PTSD dogs, and so the dogs that they choose for that service track, they're very empathetic, and they'll sense when a person's having a nightmare and they'll wake them up and soothe them, which I think is really awesome that a dog can do that. And just having the dog around helps decrease the anxiety, which the only side effect of a dog is that you have to clip their claws. So that's a pretty good side effect, I think. So somatoform or factitious disorders are amazing and interesting. And there's no good explanation for how they happen. But it's basically physical symptoms that closely mimic authentic medical conditions. The symptoms are not under voluntary or conscious control, so it's not that the person is faking it. They really feel those symptoms. They're actually true symptoms, but there's no physiological basis for their complaints. So it's very difficult to diagnose these because um, they're real symptoms and they're very real to the person. They're not under their conscious control. They're not voluntary. The person's not just making up these symptoms. They're actually feeling them, but there's no physiological basis. So there's no way to clinically test. And basically, they usually test by ruling things out. So the three types that we're going to talk about are somatization disorders, conversion disorder, which is kind of a subcategory under somatization disorders, and hypochondriasis. So, somatization disorders are chronic complaints of physical symptoms without any physiological basis. So, in order to be diagnosed with somatization disorder, you have to have complaints with at least four pain symptoms in different sites, two gastrointestinal symptoms, one sexual symptom, and one pseudoneurologic symptom. People with somatization disorders often shop around for medical caregivers because they go to a doctor and the doctor's not telling them what they want to hear. They're not finding a reason for their problems. And so then they go and find another doctor. And it is very difficult to get good continuity of care when you do that. Um, the other thing that happens is people get frequent or multiple surgical procedures because, oh, it's the next surgery that's going to fix you. um, it's the next thing that's going to happen. And it doesn't because there's no physiological basis. So it's not going to fix you. So it is really difficult to diagnose and difficult to treat. Sort of the subcategory underneath that is conversion disorder. And the main difference between somatization and conversion disorder is the symptoms with conversion disorder are always neurological symptoms without an organic cause. So with somatization disorder, it can be gastrointestinal pain, sexual symptoms, but with conversion disorder, it's only neurological symptoms. So paralysis, anesthesia, where you can't feel things, paresthesia, where you feel abnormal sensation, loss of hearing or sight, or dizziness. And we get a lot of people who get prescribed therapy for conversion disorder because they have neurologic symptoms. And they're not, a lot of times they're trying to rule things out and they're not diagnosed yet, maybe with suspected conversion disorder. So, what we can do in physical therapy, and because I work in an outpatient neuro clinic, I've probably seen more patients with conversion disorder than a lot of people. Um, what we can do is we can work on functional mobility. So, despite the we don't know the cause, we can still work on improving their mobility. They are probably going to have to also get other types of therapy, like cognitive behavioral therapy or some other type of therapy, in order for it to completely go away. But it is very interesting working with people with conversion disorder. Their symptoms are real. They're not consciously doing these symptoms, but there's no organic cause for them. But we can still work on all the things we work on with everybody else: functional mobility, balance, gait training, everything. One time I worked with a woman, and this was in an inpatient setting, and her manifestation of um, conversion disorder was that she had narcolepsy and she had fallen asleep while driving her car from the narcolepsy and got in an accident and broke both her legs, which is why she was in the hospital. Um, and I worked with her, a very interesting uh, course of treatment that we went through. And she had paresthesia, she had anesthesia, she had difficulty looking at her injuries. And so we worked on some desensitization. We worked on strengthening, mostly bed mobility, that sort of thing. But you would just because someone has suspected conversion disorder, and as you can imagine, there's no sure way to diagnose it, but doesn't mean that you can't treat them the same way you would treat someone with these same symptoms. So very interesting. I've actually had some good luck with working with the people that I think recover best from conversion disorder are young people. And I've worked with several of them. Hypochondriasis is we've probably all heard hypochondria, where it's persistent preoccupation with health and physical condition in the absence of organic problems. So fear of disease, fear of illness, fear of death. The tendency to self-observe, hypersensitivity to bodily functions, like saying, "Oh, are my lymph nodes swollen? I think they're swollen. Maybe they're not. Here, feel my lymph nodes." I'm just exaggerating, but it's just like there's no organic problem, but the person still is hypersensitive to any minor changes, and they perceive it as being disease and illness.